So obviously if we look at objective monitoring or objective measures in Parkinson's disease, luckily we see, especially in the last couple of years, that interest for it is increasing. We're here at the AAN, and one of the sort of themes they have is wearables and technology in Parkinson's. What we see is that most of these technologies are employed to look at motor symptoms. So most of them look at bradykinesia, dyskinesia, tremor, and obviously that's a very good thing because you can use it to have an idea about how a patient is doing rather than having a snapshot in your clinic. But we also see, luckily, that interest is increasing for the non-motor symptoms, and obviously it's not as easy as for the motor symptoms, because obviously if you have a tremor or if you move too much or too little, you can pick it up, for example, by a smartwatch or any other kind of device that picks up movement. Non-motor symptoms mostly you can't see, so we tend to rely on scales and questionnaires to ask the patient, what are you experiencing, how severe is it? And we know these are quite unreliable because people tend to forget to report things, or people, if you ask them, how have you been doing for the past month, they will tend to think back about the last 3 to 4 days. But what we see is that you can use, and that's actually part of our research at King's, that some of these motor outcome measures, for example with wearable watches, also can be used as a surrogate marker for non-motor symptoms. So one of the things we've shown, we actually have a poster here at the AAN, is that it quite actually can pick up on constipation. So what we see is people who are very bradykinetic, so very slow, very rigid, you get a score for that based on the watch, on the wearable, and that correlates very nicely with constipation. And also a few other non-motor symptoms which can act as a surrogate marker based on your bradykinesia score or your dyskinesia score. So slowly we're getting there, but obviously more work and more effort needs to go into that to have an idea on what we can do in terms of non-motor monitoring. So obviously we have a lot of drugs for Parkinson's disease, and then always the question is, can't we use some of these drugs and repurpose them for other symptoms other than the symptoms we're currently using them for? And that's one of the other things we do at King's, or have been doing for the past couple of years, is looking at the existing medication, how can we reconfigure this to address some of the unmet needs, especially when it comes to non-motor symptoms. And I think the best example I can give you of that is a project we're currently working on, which is called the apomorphine study. And what we do with the studies, we're having a look at our patients who are on apomorphine treatment, especially those who are on long-term treatment, and we look at the effect it has on the deposition of a specific protein in the brain, which is called amyloid. And amyloid obviously has a clear role, and this has been mainly shown for Alzheimer's, but also known for Parkinson's disease, has a clear role in cognitive issues and memory issues. And we know, based on rodent studies, but also a human post-mortem study, if you give people, and in this case Parkinson's patient, long-term treatment with apomorphine, that they are less likely to develop this amyloid deposition in the brain. So what we currently do is we try to look at that effect in vivo, so in patients who haven't died yet, to see what the effect is. So we have them undergo a scan, an amyloid PET scan, look at the amount of amyloid they have in the brain and what the effect of apomorphine is on that. And what we see, it's only preliminary results unfortunately so far, but tends to be very positive in that those people who have been treated with apomorphine have less amyloid than those who haven't been treated with apomorphine. So that's clearly something that's very promising, and we're trying to do the same with other therapies as well. One other example of that is, for example, the vertigotine patch, which is one of the dopamine agonists. Obviously we use that to treat motor symptoms, again things like bradykinesia or tremor, but we've also noticed, and that's been published in several studies now, that this patch specifically also addresses pain in Parkinson's as one of the treatments that you can also use for pain. So those are just a few examples of how you can sort of repurpose existing drugs without the need of having to develop new drugs for the specific symptom you're looking at. Yes, so following up a bit on what we've already discussed, so what we see in terms of the effect that levodopa, so intrajejunal levodopa infusion and apomorphine treatment, the apomorphine infusion have on non-motor symptoms is very broad, and in the last couple of years there have been several trials published on the effect, mainly the non-motor effects of these treatments, because we already knew they were very effective for motor treatments, for addressing motor fluctuations. But what we see with both of these treatments is they have their own profile of addressing non-motor symptoms. So what we see in patients who have been on these treatments for longer periods of time, we see improvements in urinary problems, urinary dysfunction, also sexual problems, constipation, I think already briefly mentioned in one of the previous questions. So what we luckily see that we can use these existing therapies without having to actually look for other therapies. It's always good to develop new therapies, but we can already use what we have, things that have been around for many, many years. For example, apomorphine has been in use since the 1950s for motor symptoms in Parkinson's, but we can actually reuse all of this to address non-motor symptoms in PD. And luckily we see more and more research coming out on these topics, on both of these infusion therapies, specifically looking at non-motor effects. So that all looks very promising, and obviously we hope to develop that a little bit further to really prove that you can use this for non-motor symptoms, because people tend to have this idea, which I mentioned as the very first thing, that there are no treatments for non-motor symptoms, and actually some people, as I mentioned before, are not even aware that non-motor symptoms are such a crucial part of Parkinson's disease. So hopefully with all this new evidence coming out, we're hoping to show that it's actually very useful to think about these treatments and not forget about the non-motor symptoms in Parkinson's.